All right, we'll get started. Welcome to the CortiCare Webinar series, which presents topics related to EEG and neurodiagnostics, patient care management, research, and future applications. Today's event will last approximately an hour, and in about an hour, you will receive an email with a link to an evaluation form for this webinar. We welcome your feedback, and if you wish to receive a certificate of completion for one asset continuing education credit, please submit the completed online form and a certificate will be sent out to you in the next few days. On this webinar platform, you may enter in questions in the chat area, which, time permitting, we will address at the end of the presentation. By the way, by registering for this webinar, you automatically will be notified of our future webinars. The next webinar is scheduled for April 28th, when Dr. Salim Benbedis from University of Florida and Tampa General Hospital will present on the assessment and treatment of psychogenic non-epileptic seizures. Presenting today is Dr. Hiba Haider. Dr. Haider is an assistant professor of neurology at Emory University School of Medicine, an associate director of EEG services, and co-director of the critical care EEG monitoring program at Emory Healthcare in Atlanta. As an adult epileptologist, she focuses her practice on the medical and surgical management of refractory epilepsy patients and in critical care EEG monitoring. Dr. Haider's academic interests include implementation science and quality improvement in status epilepticus and other seizure emergencies and their impact on clinical outcomes, and in the use of functional connectivity as a biomarker in Norse autoimmune encephalitis. She is co-editor of the Handbook of ICU EEG and speaks nationally and internationally on that topic. Today, her topic focuses on the impact that COVID-19 has had and continues to have on the delivery of healthcare, specifically its impact on the assessment and management of patients with epilepsy and other seizure disorders. I now hand over this presentation to Dr. Haider. Please come on board. Thank you, and I will let you take over.
Okay, sounds great. Thank you everyone for joining, and thank you for having me here today. I will be talking today about the care of epilepsy patients in the time of COVID-19. And these are my listed disclosures, none of which are actually relevant to this presentation, except that I do consult for Cerebell, which is a rapid EEG device, and I will mention that in passing. So the objectives of today's talk are to basically cover the pathophysiology of COVID, and especially as it relates to the empirical risks of seizures in the setting of patients who are acutely infected with SARS-CoV-2 or those who have pre-existing epilepsy and have SARS-CoV-2 infection superimposed. We will also talk about the impact of the pandemic on epilepsy care in the outpatient and inpatient setting, particularly on the inpatient EEG workflows and EMU evaluations. And then we will cover briefly the EEG findings as what we know about them currently in COVID-19 patients, and especially focusing on which patients are at highest risk for having epileptiform abnormalities and whether there are relationships to outcome that are known at this point. And lastly, we will review monitoring and staffing strategies in the light of limited resources. As you know, we are all operating in a circumstance of limited resources, both in terms of staffing and PPE, and at the same time trying to be judicious with exposure to our staff and patients. And also we will cover a little bit about improving EEG interpretation in this setting. So let's talk first about the risk of seizures in patients with acute COVID-19 infection and those with pre-existing epilepsy. So early on in the pandemic, there were multiple reports that surfaced about neurologic findings in COVID. COVID-19 patients. And these were smaller studies, and many did not control for the severity of disease and other factors that would lead to the occurrence of neurologic manifestations. But they included a variety of findings, including anosmia and ageusia, impaired consciousness that, again, in turn can be multifactorial and can result from any number of systemic insults, including in the setting of sepsis-associated encephalopathy or hypoxic ischemic encephalopathy, and so on. And then there were also seizures and strokes and vasculitis that were reported, as well as peripheral neuromuscular disorders. But then a larger study that was a retrospective study from China of lab-confirmed SARS-CoV-2 infected patients that included both outpatients and inpatients, 1,100 patients total, came out that again showed that there were no definitive signs or symptoms, neurologic signs or symptoms on presentation. So early on, neurologic signs were not seen, although they did find that headache, fatigue, myalgias, and arthralgias were fairly common in this population, which may indicate kind of a non-specific inflammatory process. They found that only 1.4% of all their patients had some kind of cerebrovascular disease as a coexisting disorder, while seizures or epilepsy were not a coexisting problem in that cohort. And then two other studies that were initially peer-reviewed but then were published later on and were hospital-based also showed similar findings with no definitive early neurologic signs or symptoms in these cohorts. And so this lack of early neurologic signs or symptoms in these large cohorts of patients suggested that perhaps direct CNS infection or invasion of the virus is actually not responsible for the early presentation. And then there was another study from Wuhan of 214 hospitalized patients that showed that at least a third of their patients had neurologic signs or symptoms. And the more severe infections, as marked by their need for mechanical ventilation or ICU care, those were the ones that were more likely to have CNS manifestations of impaired consciousness or acute strokes. And there was only a single case of epilepsy in the more severe cohort. And then another study that looked at new onset acute symptomatic seizures at 42 hospitals in Hubei province, which was then the epicenter of COVID in China, in 304 patients, again, found that about a third of them had severe disease, again, due to mechanical ventilation needs and respiratory status. And many of those patients presented with acute strokes or multiple systemic disorders or multi-organ failure that could eventually provoke seizures, but none of those patients actually had acute seizures during their hospital stays that were noted. So they also concluded that SARS-CoV-2 infection, at least early on in the course of infection, poses a minimal risk for acute symptomatic seizures, although there was a significant proportion of severely ill patients that theoretically could have resulted in seizures because they had many provoking risk factors. So to summarize, the general principles of what causes seizures in the hospital setting, those general principles pretty much remain the same. They have not changed despite the fact that we are in a pandemic with a disease that we don't know a lot about. And it seems that COVID-19 could exacerbate seizures, but more likely because of associated systemic effects and multi-organ dysfunction that is not directly related to SARS-CoV-2 infection and invasion. So all available reports of seizures in the setting of SARS-CoV-2 infection should be interpreted in this context. So when we talk about the mechanisms of how the nervous system is infiltrated, there are several purported mechanisms, and the most commonly accepted one is that the virus transmits via the olfactory bulb. We know that the olfactory epithelium is enriched with cells that express these two receptors, as well as the cathepsin L protease, which increases tropism for the virus. So that's a well accepted mechanism. There's also the hematogenous route, where we also know that ACE2 receptors are richly expressed in endothelial cells of the cerebral blood vessels, or it may hitch a ride with an immune cell. So that's the hematogenous route. And then the last possible mechanism is via transsynaptic transmission and using methods of retrograde neuronal protein transport from the nerve terminals of the vagus nerve located in the respiratory system and the GI tract. So those are the three purported mechanisms of direct CNS invasion. But overall data is mounting that those direct mechanisms of viral neurotropism are likely responsible for a very small number of cases that result in neurologic dysfunction. So this direct invasion is probably rarely results in that consequence. Most neurological manifestations are seen in patients who have a very hypercoagulable state or a hyperinflammatory state ongoing. And also there is emerging evidence that there is immunologic crosstalk between the brain and the lungs in the lungs of mechanically ventilated patients, because mechanical ventilation by itself triggers an inflammatory cascade that results in end organ dysfunction. So that is also a new and emerging area of research in this disease process. So to summarize, the risk of seizures and the risk of worsening of epilepsy patients with COVID infection, we covered that there is minimal early involvement in patients that argues against direct CNS invasion. And this is relevant for when you consult on neurology on patients who are not neurological patients and don't have pre-existing brain lesions, and they have acute infection with COVID-19. Later manifestations could be related either to systemic complications of severe cases of infection or direct CNS invasion. We don't have enough data to be conclusive about that. And then seizures and epilepsy are very infrequently worsened by COVID-19. And more commonly, this is seen with severe cases. And of all the systemic and environmental factors that relate to COVID-19 infection provoking or causing seizures, an underlying susceptibility to epilepsy is likely a very significant factor, although there are very small numbers of patients to kind of glean this data from. So now we'll move on to epilepsy care during the pandemic. And as you all know, pretty much every aspect of healthcare has been impacted by the pandemic. And these are the results of a survey. The members of the American Epilepsy Society were surveyed between April and June 2020. And their response rate actually was only 9%. And so they had 337 respondents to analyze after screening out those who were non-completers and those who did not who were not directly involved with patient care. And the majority were physicians from the US. And what they found was that majority of them felt that their patients experienced at least some barriers in terms of receiving appropriate clinical care, receiving timely neurophysiologic procedures and elective surgeries. Medication shortages were noted by about a third of respondents, with no particular patterns in the types of medications involved, although this was early on in the pandemic and has probably since then has changed. So that is a limitation, that this was a survey just in a snapshot in time in a rapidly evolving situation. And the barriers that most of them appreciated was the loss of employment and financial stressors leading to a lack of insurance coverage and the lack of access to healthcare services due to closures and restrictions in elective care. And then another big one was just the anxiety and fear related to the viral outbreak, which was preventing people from seeking adequate care. So one thing that did emerge from that survey is that telemedicine is of huge value and is probably here to stay in some capacity in the long run. It is our new normal, and there are synchronous and asynchronous models of telemedicine. Excuse me, synchronous referring to live video conferencing, and asynchronous telemedicine referring to acquiring medical data and then transmitting it to a specialist at any given time for assessment offline. And as we continue through this pandemic, it's important to emphasize to our patients that they need to continue to seek care despite the fact that we are in a pandemic. And even though we know that telemedicine is not without its challenges, there are barriers, specific, and especially for specific populations. There may be cultural, limitations where some patients may not be comfortable taking these calls in their homes or in their workplace, where they feel like their stigma may be magnified, or there may be personal preferences. Certain populations, like establishing, a good rapport or communication with a pediatric patient or a teenager is very hard over telemedicine. Similarly, patients with cognitive or hearing impairments may not do well in that environment because to be able to have a complete and comprehensive assessment. And of course, language barriers and the obvious technical challenges of bandwidth and availability of the internet are also issues. So what constitutes a successful high-yield telemedicine visit? I put in a reference here to a brief article that outlines a checklist for clinicians about what to ask. And a lot of it, you can refer back to it, a lot of it is fairly self-explanatory, but a few themes emerge from the article overall. The overarching rule should really be to ensure the safety and identify all the risks and manage risks appropriately for any given patient. In general, it is recommended that we be conservative with regards to treatment adjustments and changes, because if the healthcare system is under strain, then postponing medication changes that have any risk of eventually necessitating a visit to the emergency department would probably be a good idea. There may be patients who are well controlled on a seizure medication, and you're at the point where you might want to consider, tapering them off of seizure medication. But in general, this is being discouraged at this time, even if they are at a fairly low risk. But again, there may be patient-specific factors that you may want to consider when making those decisions. On the flip side, for example, if a patient is currently unemployed because of the pandemic and thinks that this is as good a time as they will ever get to try and wean off a medication, in terms of having a recurrent seizure in the process, then you would take care of, assess those risks on an individual basis. And then obviously guiding them about their emergency care plan, when to go to the emergency room versus when to call the clinic for help. And tied into this would be the threshold for medication use, for rescue medication use, such as benzodiazepines. You may find that even very well-controlled patients may warrant a prescription for a benzodiazepine just temporarily to, if they have auras or easily perceived aura that results in seizures, they may want to minimize their risk by using a rescue medication in that instance. The other thing to keep a good pulse on is mood disorders. So there are several well-validated questionnaires out there for the assessment of depression, anxiety, and quality of life. We all know about these, but I think they have a lot of value if they can be incorporated somehow in your clinical workflow. It's easier to keep a longitudinal assessment of how your patient is doing rather than a subjective, depending on a subjective report of how the patient may be feeling the day of their appointment. A quick word about anti-seizure medications. There are not a lot of interactions that we know of, but one common one is that steroids are often used in patients with acute COVID infections, especially more severe infections, to reduce the inflammatory response. And plasma levels of steroids can be reduced by enzyme-inducing seizure medications like phenytoin and carbamazepine and phenobarbital and so on. And so it's important to be aware of that interaction, because if a person is on an enzyme-inducing anti-seizure medication, then they may require higher doses of steroids to have the same effect. And the other thing is that orally given steroids have a pretty significant first-pass metabolism through the liver when they are absorbed. And so that decreases their levels even further. So if the patient is being observed in the hospital, or to whatever extent possible, IV dexamethasone is preferred for the longest possible duration of time before converting them to PO steroids in patients with patients with enzyme-inducing agents on board. And the last thing is in this realm is that first seizure in a patient with acute COVID-19 should be dealt with as a first seizure in any other instance. If you feel, a lot of those acute symptomatic seizures may not require long-term treatment with seizure medications, but if you feel that there are enough risk factors in the patient's history that would push you toward prescribing chronic anti-epileptic medication therapy, then you may want to avoid enzyme-inducing agents in that case. And just to stress again that mental health considerations, there's layers upon layers of stress on our patients that are related not just to their epilepsy and seizures and stigma and the side effects of their treatments and so on, but also related to their limitations during the pandemic, just ranging from basic anxiety about it to limitations of not being able to follow their routine and having to stay indoors, and caregiver stress and the economic insecurity that comes from it. So to keep a pulse on that. Several organizations have a lot of really comprehensive resource pages out there, including the ILAE, the AES, and the AAN, and you can go and check those out. These are both patient-facing information as well as physician-facing, and I would encourage you to bookmark those and potentially share the patient-facing ones with your patients, because these are good sources of information. So now we'll go to the EEG findings, what we know about that in COVID patients, and focusing on which patients would be at highest risk of epileptiform findings. So this is probably not news to most of you. We know that in the inpatient setting, in the critical care setting especially, most seizures that we encounter are non-convulsive or silent seizures. Patients are not convulsing. They may have some kind of very subtle symptom, but like nystagmus or hippus or a facial twitch or a gaze deviation or just impaired consciousness. But for the most part, there's really not a whole lot going on. And this graph here shows a summary of some of the data looking at the prevalence of non-convulsive seizures and non-convulsive status, which is the blue and the red bars respectively, in several different cohorts of patients. And as you can see, the highest risk is patients who have generalized convulsive status and are altered after that. And of course, pretty significant incidences of seizures and status in all these other cohorts. This is not meant to be an exhaustive, summary of the literature on this. And it's important to know when reviewing these kinds of graphs is that these are all biased assessments, right? These are patients who we chose to hook up to continuous EEG because we thought that they may have an increased risk of seizure for some reason or the other. So these are not true epidemiological assessments, but nevertheless, for patients who we do decide to hook up, the yield of continuous EEG is fairly substantial, considering that it is a non-invasive diagnostic test. After prefacing with that, this is a graphic abstract of a systematic review that was published last year in November in Seizure. And the indication for performing EEG in this cohort of patients was, by and large, over 90% that they were altered or poorly responsive after the withdrawal of sedation. And then a smaller number because they had some kind of clinical event that was concerning for seizures. This systematic review looked at 29 studies and totaling a case load of 177 cases of COVID-19. And only, I believe, 10 of these 29 studies employed continuous EEG. The rest of this data came from routine EEGs. And what they found was that, by and large, the most common EEG finding was that of a non-specific diffuse generalized slowing. Focal slowing was also seen in about 8%. Epileptiform discharges were fairly common in about 20% of patients. And but it's important to note that only they reported that only 8 of 177 cases had a history of seizures. But with a caveat that many of the studies did not look into a history of seizures and then did not report it as part of their in their manuscript. So these data have to be kind of taken with those caveats in mind. So it's probably worth going into a deeper dive with some of those EEG studies. And these are some of the more recent ones or bigger ones that have been published. The largest series was a multi-center cohort, just came out less than a month ago, that looked at 197 patients on continuous EEG across 9 centers. This is a summary of all of those studies. As you can see, there is a fair amount of geographic diversity. They range in their reach all the way from the Bronx and an academic healthcare system in New York City to Cleveland to Paris. And then this multi-center study that involved academic centers in the US and Brussels, and then Chile. This was the only prospective study. And the sample sizes range all the way from 19 to 197. The smaller studies, the majority of the smaller studies used either routine EEGs or rapid EEG devices like Cerebell, like an 8-channel headband. The two biggest studies, the one by Pellinen and colleagues from NYU and Lin and colleagues, which was the multi-center study, the majority of their cohort was actually continuous EEG, full montage, with a small proportion being Cerebell rapid EEG. And when you look at the EEG findings from these studies, you can probably start here on the right side of the page and look at the most malignant finding first. Non-convulsive status epilepticus was actually fairly uncommon, 0 to 6%. So overall low prevalence of non-convulsive status, and 11% for seizures. And sporadic epileptiform discharges were found anywhere from 0 to 41% of patients. And of this one from the Bronx, which showed a 41% prevalence of sporadic epileptiforms, the majority had, I think all except one patient had frontal sharps in this series. Again, the caveat, and similarly, similar to that systematic review, that the most common finding was diffuse slowing. And when you consider the yield of epileptiform findings across these studies, it's important to note the caveat that a large number of them were either on anti-seizure medications or sedation. A small proportion of many of the cohorts had a history of epilepsy. Predictors of epileptiform findings, the NYU study showed that having epilepsy or a seizure prior to hookup to EEG those two were independent predictors of having epileptiform EEG findings later on. The multi-center cohort by Lin et al. Showed that, again, preceding clinical seizures, that increased significantly the odds of being in non-convulsive status epilepticus or having electrographic seizures. And also that a pre-existing intracranial lesion on neuroimaging was more likely to be associated with non-convulsive status epilepticus. And again, in the remainder of the studies, these things did not quite pan out. They did not, severity of disease or presence of clinical seizure or presence or absence of imaging findings were not significantly correlated. But again, small studies, difficult to find an effect in that case. Timing and duration. This graph is from the NYU study, which was, again, the second largest series. And the graph here shows the duration of hospital admission, going all the way from the beginning, 0 days, all the way across over a month. And the y-axis, each point is a patient. And so the length of the lines here indicates the length of monitoring of the patients and why they were monitored for varying indications. And they found that there was a bimodal distribution during the course of the hospitalizations where there was an early initiation of continuous EEG for a good chunk of patients here following, these were either patients following cardiac arrest or those admitted with seizures, or later on, several days out, where testing was ordered, EEG was ordered primarily to evaluate for persistent encephalopathy with a median monitoring duration of 1.3 days. And these were the indications. In terms of outcome, the NYU study did not find that EEG findings correlated with mortality at all. The other big study by Lin and colleagues found that electrographic seizures were an independent predictor of in-hospital mortality, and also hospital length of stay increased in the presence of non-convulsive status epilepticus. Okay, so summary about the EEG findings. There's no EEG signature for COVID. The most common EEG finding is diffuse slowing. And initial EEGs typically do not show an encephalitis or cortical irritability, although it has been reported. And again, the bigger series are confounded by the fact that a lot of those patients are on sedation or anti-seizure medications. The risk of electrographic seizures is highest in those presenting with a clinical suspicion of seizure or a clinical seizure and a history of epilepsy. And it still remains to be shown about which subsets of patients will have epileptiform findings, when they will have them, what the severity will be, and why what the etiologies are. With a few exceptions, the two studies that I focused on, most other studies are smaller sample sizes, but I'm sure we will get more data about this going forward. So moving on to COVID, screening and triage for EEG. So in the outpatient setting, it goes without saying that COVID positive and patients under investigation, likely you can postpone most outpatient EEGs. This is, it's unlikely to be detrimental in most cases. But overall, it's important to just consider the clinical impact of why you're doing the EEG as an outpatient for an outpatient. If you already have a treatment, if you've evaluated the patient, if you already have a treatment plan formulated, then what is the EEG at that point going to change? That should be an important consideration. Of course, before they come in, the patient should be screened for symptoms, and scheduling the EEG the same day as an in-person visit for new patients, if that is what your institution is doing, is probably a good idea, because that makes contact tracing easier and reduces exposure risk both for our technologists and for the patients. There is a lengthy guiding kind of document on the NAEC website that is the combined expertise of representatives from the ACNS, AES, asset and the American Academy of Neurology that talks about all the considerations that need to go into reopening epilepsy centers in the light of of the COVID pandemic. And it's a really great document. I would encourage you to look at that if about questions related to this. But we'll cover some of this in a bit of depth. When it comes to screening and triage for epilepsy monitoring units, we know there have been several surveys that have shown this, that epilepsy monitoring units had to close down across the country, across many countries, really, and many of them are now starting to reopen, probably not to full capacity for the most part. So it's important to risk stratify who needs epilepsy monitoring unit evaluations and how quickly. There are diagnostic cases where you want to differentiate seizures from other non-epileptic causes of paroxysmal behavioral changes, non-epileptic events. So for that, you could consider doing home ambulatory video EEG testing, which has been shown to have a pretty good, almost comparable yield to inpatient diagnostic EMU evaluations. In some cases, it may also be a good option to quantify seizure burden or interictal epileptiform discharge burden, if that will help you make some treatment decisions. The technology here has really evolved, where longer recordings, up to 2 weeks even, are possible, and in-home multi-camera settings setups are possible. And now this data is able to be streamed, enabling intermittent monitoring by the staffing physician or a different staff member who can pick up on artifact or anything that requires troubleshooting on the patients, and they can then dispatch an on-call technologist to troubleshoot and limit artifacts. Obtaining home videos from patients is also very important in deciding whether or not you can get away with using home EEG, or that your patient really needs a diagnostic EMU evaluation. And of course, before referring patients to the EMU right off the bat, it would be probably a good idea to try a broad spectrum anti-seizure medication and see if they fail that empiric treatment trial before sending them to the epilepsy monitoring unit based on your suspicion. For surgical patients, obvious things, you want to assess the urgency and the disease burden, how frequent their seizures are, what the chances of capturing the seizures might be based on the frequency and epilepsy syndrome, and what their SUDEP risk might be, whether or not they have frequent GTCs or nocturnal seizures, and the potential impact of any surgical intervention and how fast that would happen anyway. You may want to, if it is a pre-surgical patient you want to proceed with, get the rest of their workup done while you're waiting on an epilepsy monitoring unit evaluation. And this is never really considered enough, but gauge the willingness of the patient to also proceed with this very prolonged workup. That is a very involved process, and whether they are willing to do this at this time. For epilepsy monitoring units, when the patients do come in, pre-admit COVID testing is, for the most part, available in a lot of places. And, it's recommended that EMU scheduling staff pre-screen a detailed symptom checklist when scheduling them, and then 2 to 3 days prior to admission and on the day of admission. And also early on, when scheduling them, bring up with them potentially if they are able to self-quarantine for up to 2 weeks prior to admission. There are medical services like OBGYN and surgical services that actually are doing this to try to minimize risk when possible. So that is also an option. And then obviously to keep up with your current hospital policies on visitation and whether or not caregivers can be present or not. And that is also part of it. Going on to inpatient EEG. For patients under investigation, it's good to know your institution's turnaround time for COVID PCRs. If it's just a couple hours, it's probably best to postpone an EEG hookup until the results are available. And in the meantime, treat empirically for seizures if there's a high suspicion for that. For COVID positive patients, we, at least at our institution, have put into place a protocol where approval is needed either by an EEG attending or by a clinical neurophysiology supervisor, that will help find who the highest risk patients are. People who have previously been on status or are at high risk of status based on their clinical profile, or whether they've had a previous clinical seizure and now are comatose, cardiac arrest patients, and also in an attempt to minimize exposure, because oftentimes for the same patient, routine and continuous orders can be put in by different ordering physicians on the same treatment team, or you may be looking at doing a routine first, and then depending on what that shows or doesn't show, deciding on whether that patient needs a continuous EEG. So there may be, reasons to consider to do a prolonged or an extended routine in patients just right off the bat instead of 30 minutes to look at what epileptiform findings there may be. And we'll talk about this in subsequent slides. And then rapid EEG devices, obviously, which we'll also look into, which can be applied directly by the patient's care team instead of exposing the technologist to multiple times. So these are in terms of who to monitor and how long to monitor. This is the result. These are the results from the landmark study from 2004 by Clausen and colleagues at Columbia, which showed that 92% of the seizures that they diagnosed were exclusively non-convulsive. 88% were detected within 24 hours, but another 5% and 7% were detected between 24-48 and after 48 hours. And there was a clear dichotomy between non-comatose patients and comatose patients. It took longer for the comatose patients for their first seizure to manifest. And so based largely on that landmark study, the prevailing guidance is that if somebody is not comatose, 1 to 2 days of EEG recording is what you need to be fairly confident that you've ruled out that this patient is going to seize acutely, and 2 to 3 days even for comatose patients. And obviously you need continuous EEG if you're treating refractory status. But the question is, really, does every non-comatose patient need 1 to 2 days? Does every comatose patient need 2 to 3 days or more? And how soon can they be disconnected from EEG in order to speed up the availability of our machines to patients who need it? So this is the 2 helps 2B score that further helps us parse that out. This is a risk stratifying score that came out of a multi-center study, Emory, Brigham and Women's in Yale. And basically the summary of this is that if your patient has had a prior seizure at any time, they get 1 point. On top of that, if the first hour of their EEG shows any epileptiform findings, brief rhythmic discharges, PDs or rhythmic delta that are focal, plus features, a high frequency over 2 hertz of discharges, or the periodic patterns that you might see, or sporadic epileptiform discharges, then those findings accrue more points on top of it. And so if your patient has none of that, no prior seizures, no epileptiform findings, then they are in the 0 risk category, and their predicted risk of seizures over the next 72 hours is 5% or less. And that number increases as the score increases, okay? And then this score was then validated on a separate cohort of 1,500 patients from several centers. And what it showed was that risk basically declines, and is that rate of decline is different for different cohorts. So here's the 0 risk. Here's the 0 risk category, who had nothing on their first hour of EEG and no prior clinical seizures. And for that population, the lowest risk category, you only need 1 hour of EEG before you are 95% confident that that patient is not going to seize in the subsequent 72 hours. And to reach a 98% confidence, you only need 3.3 hours. And obviously that number increases, that duration of EEG increases for the moderate risk and the high risk categories. So this is just, and of course, this was pre-COVID. This is not validated in COVID patients, but this is just a tool that can help you decide and probably even make it protocol to try to do a prolonged EEG right off the bat, so you can assess your patient's 2 helps 2B score, and then decide whether or not they need continuous EEG and for how long. Minimize time in the patient's room. There's CAPs, templates, rapid EEG devices that are all available. They do come with some limitations. Obviously, they can be sometimes prone to artifact, even though they speed up time to hook up pretty significantly and decrease our technologist exposure. The quality can vary and deteriorate over time. Considering other alternatives to collodion, which can be time consuming and also involves the use of an air hose, which can potentially be an aerosolizing procedure. So your techs may, if it's it's going to be a few hours of EEG, they may consider just a simple head wrap or a EC2 paste or something else. Also, keeping the acquisition machine outside the room of the patient may also be an idea to prevent them from having to go in for restarting the study and so on. As you know, healthcare workers have a pretty high risk of contracting COVID-19, and this risk is actually high in ethnic minorities. And so we have to be pretty accepting, and we have to acknowledge the fears and the anxieties of our technologists, who really are our frontline healthcare workers, and be aware of your staff that may have high-risk conditions or high-risk situations at home. The techs really do have much more of an exposure risk than we do as neurophysiologists. So where possible, where there are big teams of technologists present or adequate staffing present, you may want to be creative with your staffing models. You could have rotating COVID-pacing technologist teams who kind of take all the brunt of all the COVID patients' EEG hookups for several days in a row, and do things that way. So be creative in that sense. Appropriate PPE a year down. I think most people are pretty familiar with this. You can look at the CDC guidelines. Masking the patient, using disposable electrodes, and avoiding hyperventilation as a standard procedure, except when it will be very high yield, such as in a child with staring spells where you're suspecting absence epilepsy. And then again, like I mentioned, considering alternatives to collodion to avoid the use of the air hose. That can all reduce the risk of transmission. And then maintenance and cleaning, consider covering equipment with a large plastic bag, wipe down all surfaces with an approved wipe. And if disposable electrodes are not an option, then disinfect using diluted bleach solutions. And then just a quick word about EEG interpretation. Dr. Peter Kaplan and colleagues put out a great paper on this a little while ago, last year. And important takeaways from this is that it is always a good idea to try to use standardized terminology so that going forward, we can all compare apples to apples and oranges to oranges, and actually look at this data in a more standardized way. The other thing that was interesting to note is that prone positioning of the patient, which is often recommended when they develop acute respiratory distress syndrome, ARDS, this can result in artifact in the frontopolar leads. So that is an important thing to note. Be sure that you know what your patient's position is when you're interpreting their EEG. Certain artifacts may look a little bit different when the patient is on their side or prone. So to be mindful of that. And that's especially interesting in the frontopolar artifact to me, because several studies have reported a high predominance of frontal epileptiform discharges. So we want to make sure that we are not over-interpreting artifact as something epileptiform or cerebral. And then lastly, the ACNS also has a page that details resources for COVID-19, and all the topics I talked about are updated pretty regularly and are available for review for members and non-members. And I would encourage you to also take a look at that and share that with your colleagues. And so I think that's all. I will stop there.
I say it's good to bring all this information together in one presentation. You've really covered a lot of ground, and I think it's very useful for us all to appreciate the impact that this has had on the systems that we follow in order to provide care to these patients. And I think one of the advantages that we have at CortiCare is being involved with so many of the facilities that have used our services to provide that care, both as in-home ambulatory EEG studies, as well as adding in remote monitoring. So it's something that's very timely for us. I don't see any questions at this point, so I think we can bring this to a close. Again, thank you very much, Dr. Haider. It was a fabulous presentation, and we look forward to maybe seeing you again down the road.
Absolutely. Thank you for having me.